Vijay Kevlani, Assistant Professor of Pharmacology, LG Institute of Pharmacy, Ahmedabad. Welcome to Pharma Ignite. So as you already know that we have started online lecture series for various subjects of pharmacy. So please like, share and subscribe our YouTube channel Pharma Ignite for more pharmacy knowledge. Don't forget to hit that bell icon nearby subscribe button to get latest update of our content. So let's begin our today's session, that is conventional antihistaminics, or you call it H1 antagonist drugs. So far we have studied introduction to autocoid. Then after we have started very first autocoid, that is histamine. We were talking about turnover of histamine, receptors of histamine, release of histamine. Then after we were also talking about pharmacological action and pathophysiological role of histamine. In today's session, we are going to talk about H1 antagonist, or you call it conventional antihistaminic drugs. Now, before moving to our session, let me give you a brief idea of this H1 antagonist, that these drugs generally block this H1 receptor, right? Only H1 receptor, not H2. When we talk about antihistaminics, it is about H1 receptor. So whenever there is release of histamine, this histamine is going to bind on H1 receptor present on various organ systems, and it will induce responses like blood vessel dilation. Small blood vessels are dilated and large blood vessels are contracted. Then after positive inotropic, positive chronotropic and negative dromotropic effect, apart from that allergic reactions are also produces, inflammation is also there. So this kind of response are blocked by H1 antagonist, right? So let's see this, how this H1 antagonist are acting and what is their role. So these drugs competitively antagonize action of histamine at the H1 receptor. The first H1 antagonists were introduced in late 1930s. More commonly employed now are the less sedating or non-sedating second generation H1 antihistaminics added after 1980s. So basically there are two classes of H1 antagonist. First generation H1 antagonist and second generation H1 antagonist. First generation are those which were found in 1930s, and second generation are those which were found in 1980s, right? So first generation antihistaminic drugs were too much sedating, right? So they easily cross blood-brain barrier and inhibit this reticular activating system, and that by they produce sedation, right? In second generation antihistaminics, they cannot cross blood-brain barrier that much easily, and that is the reason that they are having non-sedative properties, right? Means they don't cause any kind of sedation or very minor sedations, right? Seemingly, H1 antihistaminics have diverse chemical structure, but majority have substituted ethylamine side chain, right? Means their chemical structures, all H1 antihistaminics contains ethylamine side chain. Now if you remember structure of histamine, it is also having ethylamine side chain, right? So this structural similarity causes H1 antihistaminics to bind on H1 receptor. Here is a classification of H1 antagonist, or you call it H1 blocker, or you call it conventional antihistaminic drugs. There are two classes, as I said, first generation and second generation. First generation are those which were found in 1930s and having high sedative property, while second generation are those which were found in 1980s and having no or minor sedative properties. So first generation, there is highly sedative drugs, diphenhydramine, dimenhydrinate and promethazine. Moderately sedative drugs are phenyramine, cyproheptadine, meclozine, and mild sedative are chlorpheniramine, dexchlorpheniramine and typrolidine. In second generation drugs, there is fexofenadine, loratadine, desloratadine, cetirizine, levocetirizine, azalastine, misolastine, ablastine and rupatadine. So this all drugs are H1 blocker. Second generation drugs are widely used now for any kind of allergic reactions. Pharmacological actions. Qualitatively, all H1 antihistaminics have similar actions, but there are quantitative differences, especially in sedative property, right? So as I said, there are two generations, first and second generation. The difference is how much sedation they are producing, right? Very first is antagonism of histamine. So H1 antagonist effectively block contraction of intestinal smooth muscles, bronchocontraction, triple response and fall in blood pressure. So whenever there is a release of histamine, this histamine will cause smooth muscle contraction, which includes intestinal smooth muscles and also bronchia, right? So this responses are blocked by H1 antagonist. In bronchocontraction, remember, it is not only histamine, there are other mediators too. So in asthmatic condition, histamine are not only the drugs, or antihistaminics cannot be given, or we cannot depend on antihistaminics only. Apart from that, histamine also causes fall in blood pressure. So we have studied that in pharmacological actions of histamine, that whenever histamine binds to H1 receptor, it increases cardiac output but decreases blood pressure. That is due to specific structure of blood vessels. That is due to inhibition of myosin light chain kinase, right? So that effect is also blocked by antihistaminics drug, right? Moving on, additional H2 antagonists are required for complete blockage of that caused by higher doses. That means whenever histamine is given in higher doses, or anyone has consumed this histamine, or histamine is released in too much amount, so to block that, not only H1 but H2 antagonists are also required. Release of adrenaline from adrenal medulla in response to histamine is abolished. Contraction of large blood vessels by histamine is also antagonized, right? So as we already know that histamine release causes release of adrenaline, and this release of adrenaline causes secondary rise in blood pressure, which can be blocked by antihistaminic drugs, right? Apart from that, there is contraction of large blood vessel due to histamine, which is blocked by antihistaminic drugs. Moving on, anti-allergic action. So many manifestations of immediate hypersensitivity, that is type 1 reaction, are suppressed. Urticaria, itching and angioedema are well controlled, right? Anaphylactic fall in blood pressure is only partially prevented. Asthma in men is practically unaffected, though anaphylactic bronchocontraction in guinea pig is largely prevented. It is now well established that leukotrienes and platelet activating factor are more important mediator for human asthma. So, as we know that allergic reactions are induced by antigen antibody reactions, and that induces histamine release. So by H1 antagonist we can prevent this kind of reactions. Apart from that, there is also anaphylactoid reactions in which there is fall in blood pressure, which is controlled by H1 antagonist, right? H1 antagonist ultimately prevent this fall in blood pressure by inhibiting binding of histamine to H1 receptor, right? Second is asthma. So in asthma, leukotrienes and platelet activating factor are playing important role, where we cannot rely on H1 antagonist to produce bronchodilation, right? Moving on central nervous system, the older antihistaminics produce variable degree of CNS depression. This appears to be dependent on compound's ability to penetrate the blood-brain barrier and its affinity for the central H1 receptor. The antihistaminics, which are from first generation, which were found in 1930s, can easily cross blood-brain barrier. Apart from that, they are having high affinity for H1 receptor present in our brain, and that is the main reason that they cause sedation. Now they ultimately bind on H1 receptor present in our reticular activating system, and by that they inhibit that system, which produces sedation. Let me remind you that reticular activating system is playing important role in keeping us awake, right? So whenever that system is blocked in our nervous system or in brain, it may induces sleep. right? Individual susceptibility to different agents varies considerably. The same drug and dose may incapacitate some subjects while others may remain alert. Some individuals also experience stimulant effect like restlessness and insomnia. So sometimes ultimately it depends on patient, right? It varies patient to patient. The sedation effect of first generation antihistaminic varies patient to patient. So ultimately there are three components in effect of H1 antihistaminics. Very first is their affinity to H1 receptor present in brain. Second, their ability to cross this blood-brain barrier. If they are high lipophilic, they can easily cross this blood-brain barrier. If they are not that much lipophilic, they cannot cross, right? So that is second component. And third component is individual, right? It varies patient to patient. It is not possible that the same effect which you have experienced, I also experience the same, right? So that is the factor. Apart from that, sometimes there is stimulant effect in some patients, right? Some may experience insomnia, some may experience restlessness, right? Excitement and convulsion are frequently seen at toxic doses. The second generation antihistaminics are practically non-sedating. So ultimately sometimes apart from restlessness and insomnia, at higher dose they may also cause convulsion, right? And second generation antihistaminics, as we have seen classification, the drugs which were found in 1980s are having less lipophilic activity, or their structures are less lipophilic, and that is the reason that they cannot cross blood-brain barrier and they cannot cross or they cannot produce this CNS suppression or sedative property, right? Certain H1 antihistaminics are effective in preventing motion sickness. It is not clear whether that is due to antagonism of histamine in the brain or reflects antimuscarinic property of these drugs. Promethazine also controls vomiting of pregnancy and other causes. So H1 antagonists are used in motion sickness. Now in motion sickness there is dizziness, nausea and vomiting. Now why it occurs? So it is due to vestibular system present in our inner ear. So this sends impulse to our central nervous system, and stimulation of this chemoreceptor trigger zone in central nervous system or in specifically medulla oblongata causes this nausea and vomiting, right? Now in that there is role of our cholinergic system, means there is release of acetylcholine which stimulates our medulla oblongata or which specifically stimulates this chemoreceptor trigger zone. Now it is also blocked by H1 antagonist. Promethazine and few other antihistaminics reduce tremor, rigidity and salloria of Parkinsonism. Anticholinergic and sedative properties underlie the benefits. Now what happens in Parkinson? So there is balance, normal condition there is balance in dopamine and acetylcholine. In Parkinson what happens? Dopamine decreases and acetylcholine increases in brain. Now due to that there are tremors, rigidity and salloria. So these are blocked by anticholinergic drugs, and this promethazine is having anticholinergic property. They can block muscarinic receptors in brain, and that is the reason promethazine can be used for this kind of symptoms. Right. Some older antihistaminics, especially cyproheptadine, have appetite stimulating effect. Some H1 antagonists are also effective antitussive drugs. Right. Moving on, anticholinergic action. So many H1 blockers in addition antagonize muscarinic action of acetylcholine. The antimuscarinic action can be graded as high, low and minimal or absent. So high antimuscarinic actions having drugs are promethazine, diphenhydramine, dimenhydrinate and phenyramine. So please remember promethazine is having highest antimuscarinic action. Then after in low there are chlorpheniramine, triprolidine, cyproheptadine and cenarizine. And in minimal or absent are fexofenadine, estimazole, loratadine and cetirizine. If used concurrently with atropine or its substitute, phenothiazines, tricyclic antidepressants or disopramide, the anticholinergic action adds up. So ultimately we know that this H1 antagonist are also having anticholinergic action. Now whenever it is taken with other anticholinergic drugs, there is additive effect, means 1 plus 1 is equal to 2 like effect is seen. Next is local anesthetics. So some drugs like phenyramine, promethazine, diphenhydramine have strong while others have weak membrane stabilizing property. However, they are not clinically suitable local anesthetics because they cause irritation when injected subcutaneously. Now, as we know that to produce local anesthetic action, we have to stabilize membrane. That means we have to stop action potential. We have to close the channels present over there. Now, to do that, promethazine or diphenhydramine can be used. But they can also stimulate or they can irritate our peripheral neurons present at that site. So that is the reason these drugs are not used as local anesthetics. Moving on, blood pressure. So most antihistaminic cause a fall in blood pressure on IV injection. Promethazine has significant alpha blocking activity. However, this is not evident on oral administration, though postural hypertension can occur in susceptible individuals. So promethazine, right? First of all, it is having antihistaminic, then after it is also anticholinergic, then after it is also membrane stabilizing property, and lastly it is acting as alpha blocker, and by that it is producing this fall in blood pressure. But whenever injected IV, whenever given orally, it may produce this hypotension, and hypotension is once again due to fall in blood pressure, right? Moving on, pharmacokinetic properties. So the conventional H1 antihistaminics are well absorbed from oral and parenteral routes, metabolized in liver and excreted in urine. They are widely distributed in the body and enter brain. So as we know that whenever this H1 antihistaminic drugs are given, they are easily absorbed from our GI tract. That means they are having high bioavailability, they are easily distributed, and as first generation antihistaminics are highly lipophilic, they can cross blood-brain barrier and can enter to brain too. So that distribution is too much high, right? They are metabolized in liver and they are excreted simply in urine. The newer compounds penetrate brain poorly, accounting for their low or absent sedating action. Duration of action of most agent is 4 to 6 hours except maclozine, chlorpheniramine, mesolazine, loratadine, cetirizine and fexofenadine, which acts for 12 to 24 hours or more, right? That means whenever these drugs are having high duration of action, right, the time is too much high. That means we can give it as once a day dose, right? So doses regimen are accordingly decided. The H1 antihistaminics are mainly administered orally, but few are available for IM and IV use as well. Thank you everyone. Please like, share and subscribe our channel Pharma Ignite, and don't forget to hit bell icon for latest updates. Thank you.